The problem is when it starts to bulge out posteriorly. And that's when you get into issues there.
On that note of bulging out posterior, there's some of these fractures where the bone itself is bulging out posteriorly. When you have a compression fracture and you'll get a little bit of retropulsion of the posterior wall. One of the things I found that's nice is when you go in and expand that up, a lot of times it sucks back in, which is a helpful thing to do for the patient. You've relieved a lot of their stenosis.
That's a great point. And that's something I've had this even come from ortho spine surgeons who say, oh, well, you don't want to put a balloon in there because it'll shoot that fragment out. It's like, man, I took a couple of semesters of physics, and I don't think the free body diagrams add up in that favor. And due to ligamentotaxis, as we've seen, usually when you inflate the balloon or implant or something like that, it will typically suck that fragment back in, as you say. And so, and that's really nice because I think that the more you can get the patient back to their normal sagittal balance, I think is good, because these patients may live for a long, long time afterwards. And so I want their biomechanics to kind of be as good as I can possibly make them. And so point really well taken about that little, I've taken to, honestly, I don't have much fondness for the term retropulsion because I think it gets thrown around. I use that in the context of like a complete burst fracture, and there's fragments actually going back. And I think what you're talking about is that little, usually superior end plate bowing that you get posteriorly. And so I've taken to calling that, mild bowing of the posterior aspect of the superior end plate or something like that, because people get really worked up when they hear retropulsion. And, we're kind of talking about associations, like the association of cement going posteriorly. Oh, you got to stop. The association of retropulsion is almost taken as a surrogate for neurologic compromise, which is, it's not. But people get worked up about certain words, and so that's just something I've taken to more recently, using a little bit different vernacular to describe.
Something else on those same lines. You talked about how you want to restore the sagittal balance in these patients. This is an argument for early treatment of kyphoplasty, as opposed to getting to it 3 months later when when they're compressed down and there's no way you're ever going to fix their kyphosis. I've had patients who, once they get that compressed, they start having what's called postural fatigue syndrome, which is where there's that focal kyphosis in their spine, and all the muscles of their spine just get worn out from constantly trying to pull themselves into the correct alignment. So they wind up with pain right there at that level that relieves when you do median branch blocks, because it has to do with the facet joints there, because you're putting atypical force on those facet joints due to the kyphosis, and it has to do with the multifidus muscle at those areas just getting worn out by trying to hold things up.
Yeah, such a good point. And I would say any thoracic fracture patient who you have come back in, this is something you have to consider, is this postural fatigue. Sometimes you have them come back in 2 weeks later, knocked it out of the park, kyphoplasty, BTA, whatever, couldn't have been more perfect. They said, I got a little bit of pain right there. And usually you find if you kind of palpate them, posterolaterally, the area of their facets, that's usually where they're tender. And it can be a frustrating problem. As you said, medial branch blocks can help, and rhizotomy, even if it's needed. For a lot of these patients, tincture of time tends to do the trick. But as you say, they seem to be more predisposed towards that if their fracture is such that their sagittal alignment is already kind of mucked up. And in certain situations, try as we might, you can't always get that. You usually can't get that back to square one.
No, if it's been more than a couple of days, I usually find that I'm not going to get them back to their full alignment. I mean, and it doesn't matter what kind of vertebral body stent or other devices you're throwing in there, you're not going to get them back to normal if it's been months, just because of the healing processes that have taken place, which is why insurance companies who say, no, you have to have done 6 weeks of physical therapy before you can have this fracture repaired, makes me want to slap somebody. And I've gotten full snark mode and said, oh, really? What physical therapy would you recommend to help this fracture heal? And they obviously can't give me an answer when I'm doing a peer-to-peer because, there is no answer. The treatment for a broken bone is fix it. It's not sit and make them lift weights.
Yeah, exactly. Sit and make them lift weights and see if it'll heal on its own. And then if it gets worse, do something about it. This dichotomy of non-operative treatment versus, and I've seen patients who have progressed to, something close to a plana. And then apparently in that situation, it was, not going to do anything, not going to do anything. And the patient collapsed. And then the course of action taken there was to do a 5-level spanning pedicle screw construct. And so just this dichotomy of doing nothing versus something pretty invasive and I would say unnecessary. I just don't like that. And so I agree with you. Treating early is just the best, and you always get the best outcomes that way. And the patient is suffering less. So for me, it's a no-brainer. I really struggle with this, especially from the insurance end.
Yeah, I mean, it just drives me batty when I hear, this patient has insufficiency fractures. And the treatment that we prescribe for that, practicing medicine without a license, is physical therapy.
Show me the data that supports that. And you can't, because it does not exist. It does not exist.
And it flies in the face of all common sense as well. So
it does.
Sorry,
absolutely.
Let me get off my high horse here and stop bad-mouthing insurance companies.